This recorded lecture will be going over Chapter 43, Care of Patients with Integumentary Disorders and Burns. Many skin diseases result from infection with bacteria, viruses, or fungi, or from infestation with parasites. Diseases of this kind require special precautions to prevent spread of the infectious organism or of the parasite. Hand hygiene is a first-line measure in the prevention of healthcare-associated infections, and it is mandated as one of the Joint Commission's national patient safety goals. Dermatitis is not contagious unless a secondary infection has occurred in the lesions. Contact dermatitis is a delayed allergic response involving a cell-mediated immunity. Local skin irritation is evident within a few hours or days after exposure to an antigen. Erythema and swelling, pruritus, and the appearance of vesicular lesions follow. Many chemicals, cosmetics, soaps, latex and poison ivy, oak, and sumac are contact irritants and can cause such a reaction. Atopic dermatitis, also known as eczema, affects about 10% of the population and is more common in infancy and childhood, but does affect some adults. It results from a complex activation process that involves mast cells, T lymphocytes, Langerhans cells, monocytes, B cells that produce immunoglobulin E, and other inflammatory cells that release histamine, lymphokines, and other inflammatory mediators. Atopic dermatitis does seem to have a genetic allergic association because it's more prevalent in families. Stasis dermatitis generally occurs on the legs as a result of venous stasis and edema that is seen as in conjunction with varicosities, phlebitis, and vascular trauma. Erythema and pruritus will occur first, after which scaling, development of petechiae, and hyperpigmentation occur. Seborrheic dermatitis is a common inflammation involving the scalp, eyebrows, eyelids, ear canals, nasolabial folds, axilla, chest, and back. It is most common on the scalp. The cause is unknown. Lesions appear as a scaly white or yellowish plaque with mild pruritus. Dermatitis is diagnosed by inspection and by compiling a complete history, looking for possible exposure to causative substances. In general, treatment is aimed at avoidance of the contact irritant or allergen, good skin lubrication, preservation of skin moisture, and control of inflammation and itching. Corticosteroids may be used topically or sometimes orally or by injection to intervene in a severe episode of dermatitis. Instruct them in the proper way to apply topical agents. Caution any patient who is experiencing pruritus to avoid becoming hot, bathe in tepid water, and not puncture the vessels. The skin should be patted dry rather than rubbed dry. Acne is a disorder of the skin characterized by papules and pustules over the face, back, and shoulders. It can be classified as mild, moderate, or severe, depending on the extent and type of lesions. There are many kinds of acne, but the two major types are acne rosacea and acne vulgaris. Acne rosacea usually begins between ages 30 and 50 years. It is characterized by erythema, papules, pustules, and telangiectasias. Comedos do not occur. Factors that cause facial flushing will precipitate worsening. Tea, coffee, alcohol, caffeine-containing foods, spicy foods, sunlight, and emotional stress will all cause flare-ups. Acne vulgaris is more common than acne rosacea. Factors that contribute to the development of acne include hereditary disposition, increased androgen levels, and premenstrual hormonal fluctuations. Acne vulgaris typically begins in early puberty, continues through the teens, and then begins to subside. Occasionally it persists, or it could recur several years later. Ducts leading from the sebaceous glands will become plugged with sebum. It is not known why in some persons the ducts form these glands that become plugged, but the increased production of sebum triggers the formation of open comedos and closed comedos. It is not a contagious disease. It's not caused by uncleanliness or poor personal hygiene. Diet can contribute to the formation of lesions, but generally there is little or no relationship between the intake of certain foods and the appearance of the lesions of acne. A well-balanced diet is all that is recommended in the management of acne. Diagnosis is by history and physical examination. Acne rosacea is treated by avoiding the triggers for flare-ups, regularly using sunscreen, and using metronidazole and retinoids. Sometimes topical and/or oral antibiotics can be prescribed. Mild, non-inflammatory cases of acne vulgaris will respond well to retinoids, which are available over the counter and prescription strength. Among the topical medications, retinoic acid is the best agent for papular and pustular acne problems. Benzoyl peroxide is the most commonly used topical agent for acne, and it's available both by prescription and over the counter. Antibiotics like tetracycline and erythromycin can also sometimes be prescribed topically and orally for cystic acne to inhibit the growth of bacteria in the plug ducts. Isotretinoin has been especially effective in controlling cases of cystic acne that are resistant to other forms of treatment. This drug was initially marketed under the trade name Accutane, but after black box warnings and increasing numbers of reports of adverse events, including GI concerns, birth defects, and increased rates of suicide, Roche discontinued the marketing of Accutane in the United States in 2009. Almost all patients will experience some adverse reaction to this drug. Isotretinoin is used only for severe cystic acne that is resistant to all other treatment. There are serious adverse side effects, including organ damage and mental problems. For larger areas, lasers or a light treatment known as photodynamic therapy has been used with success. A photosensitive solution is applied to the skin and remains until absorbed. Light is then applied, which activates the chemicals, destroying the target cells. Photodynamic therapy was originally designed for the treatment of cancer cells, but it has been shown to be effective for acne. If the patient has deep scarring and pitting as a result of the cystic acne, their appearance can be improved by dermabrasion. Acne can be particularly distressing to adolescents, who are often deeply concerned about their appearance and acceptance by their peers. Following through with the prescribed therapy is important. The face should be washed gently with a mild soap. Scrubbing the skin and using a harsh soap is damaging and will contribute to inflammation. Squeezing pimples and pustules is not recommended. The hands should be kept off the face. Psoriasis is a non-contagious, chronic, recurring skin disorder that typically appears as inflamed, edematous skin lesions covered with adherent silvery white scales. These scales are the result of an abnormally rapid rate of proliferation of skin cells. The plaques most often appear on the skin of the elbows, knees, and base of the spine. It may also affect the scalp, in which case it could be confused with seborrheic dermatitis. In some cases, the skin eruptions of psoriasis are also accompanied by inflammation of the joints, especially those of the fingers and toes. This is called psoriatic arthritis. Psoriasis affects 2% of the U.S. population. There is a genetic predisposition for this disease. There is increasing evidence that the chronic inflammation of psoriasis may be a multi-system disorder. In addition to psoriatic arthritis, chronic kidney disease, cardiovascular disease, malignancy, and psychiatric disorders have all been linked to psoriasis. Diagnosis is by a history, physical examination, and ruling out other skin disorders. The disease is unpredictable, tends to go into remission spontaneously, and sometimes will clear up temporarily with or without treatment. Mild cases will usually respond to steroid creams, but there is still a possibility that eventually the disease will become resistant to steroids. Tar preparations will also act to impede the proliferation of skin cells and have long been used to heal psoriasis lesions. They can be administered in the form of baths, topical applications, or shampoos. Combinations of artificial UV radiation and a coal tar product commonly are prescribed for severe cases. This usually requires hospitalization so that the dosage of each component of therapy could be measured precisely. A form of therapy called PUVA combines the application of a class of drug called psoralens, which penetrate the skin with exposure to UV light type A. Antimetabolites have also been used to treat severe psoriasis, helping to control the disorder by their anti-proliferative action. Methotrexate is the most commonly used antimetabolite for this purpose. The skin should be kept as moist and pliable as possible. Humidifiers to increase moisture in the environment are sometimes helpful. Lubricating lotions and creams should be approved by the dermatologist before they are applied. Minor scratches and abrasions and bacterial infections can trigger the formation of lesions at a new site. Because any irritation or break in the skin seems to stimulate the growth of psoriatic plaques in a person susceptible to psoriasis, the patient should be cautioned to prevent injury of any kind. Stevens-Johnson syndrome is an allergic reaction with skin manifestations, resulting in necrosis and detachment of less than 10% of the epidermis. In 90% of patients, mucous membranes are affected. It can be caused by an infection, malignancy, or medication, or be categorized as idiopathic. If greater than 30% of the body area is affected, the disorder is called toxic epidermal necrolysis, or TEN. Lesions that may be mistaken for chickenpox can develop on the face, trunk, palms, extensor surfaces of joints, soles of the feet, and dorsum of the hands. There is evidence that a strong genetic predisposition could put patients at risk. Treatment of SJS and TEN involves discontinuing the drug and providing supportive care with fluids and nutrition. Wound care is similar to that for a burn. If not treated early, SJS and TEN can cause death. Cellulitis is an infection of the dermis and subcutaneous tissue that is generally caused by Staphylococcus. It may occur as an extension of a skin wound, as an ulcer, or from furuncles or carbuncles. The area will be erythematous, swollen, and painful. It is treated with systemic antibiotics, and boro soaks can be used to help relieve pain. Boro solution is an astringent and topical antiseptic, also known as aluminum acetate solution. Furuncles or skin abscesses are inflammations of hair follicles. The organism responsible is typically Staphylococcus aureus. Carbuncles are a collection of boils that have multiple pus heads, most commonly occurring in the back of the neck, the upper back, and lateral thighs. They can begin as a firm mass and evolve into an erythematous, painful, swollen mass. They can drain through many openings in the mass. Abscesses can develop with fever, chills, and malaise. Diagnosis is by history and examination. Treatment of any infected mass with pus is drainage of the lesion. If necrotic tissue is present, debridement should be performed. Antibiotics are given when indicated. The patient is taught to avoid using cosmetic products and over-the-counter topical remedies on the affected areas. After incision and drainage, a dry absorbent dressing is applied and changed every 24 hours. A clean washcloth and towel should be used for bathing each day until the wound is healed. Herpes simplex type 2 is most often associated with genital herpes, whereas herpes simplex type 1 lesions are primarily orofacial. Either type can cause lesions in the genital area as well as other regions in the body. When an initial infection occurs, the virus is embedded in a nerve ganglion that innervates the site of the lesion. Reactivation of the virus causes new lesions to occur at the same site. Reactivation is brought about by exposure to UV light, skin irritation, fever, fatigue, or stress. An infection with herpes simplex type 1 appears as lesions on the lips and nares that are commonly called cold sores or fever blisters. These lesions are usually painful but do not cause systemic symptoms. Diagnosis is by physical examination and history. Sometimes topical and oral acyclovir, famiciclovir, or valciclovir available by prescription will hasten healing. The symptoms of itching and burning that accompany oral herpes infections sometimes can be minimized by applying warm compresses to the sores, followed by local application of tincture of benzoin or spirits of camphor to aid in drying and facilitate healing. Contagion is possible up to 5 days after appearance of the lesion. Patients should be cautioned to use good personal hygiene to prevent spreading the virus to the eyes and genital area and other body parts. Herpes varicella zoster causes chickenpox, mostly in young people, and shingles in all ages. Approximately 1 million cases per year will occur in the United States, and about 1 in 3 people will be affected at some point in their lifetime. The risk is greater for immunocompromised individuals. The varicella vaccine is given in 2 doses to children to prevent chickenpox. The first is given at age 12 to 18 months, and the second at age 4 to 6 years. Herpes zoster begins with vague symptoms of fatigue and low-grade fever and possibly loss of appetite. About 3 to 5 days after onset, small groups of vesicles appear on the skin. They usually are found on the trunk and spread halfway around the body, following the nerve pathways leading from the spinal nerve to the skin. The vesicles eventually change from small blisters to scaly lesions and are accompanied by pain and itching. The lesions usually affect only one side of the body or face. The pain of shingles is often quite severe. Pain can persist for several days or weeks after the skin lesions are completely healed. The pain of post-herpetic syndrome is not easy to control. Diagnosis is by history and physical examination. There is no cure for herpes zoster. The condition could persist for months, especially in older and debilitated patients. The earlier the condition is diagnosed and treatment begins, the better are the chances to decrease the amount and duration of associated pain. Symptomatic treatment will typically involve administering an analgesic to relieve pain. Most healthcare providers will prescribe oral acyclovir, famciclovir, or valciclovir to diminish the extent or duration of the lesions. Valciclovir is used only in otherwise healthy patients. Tricyclic antidepressants and gabapentin, an anticonvulsant drug, have been used with variable success at controlling the pain. Narcotic analgesics are generally avoided if possible because they can lead to addiction when used for an extended time. If the pain persists and is intractable, the provider prescribes a corticosteroid to reduce inflammation. Although shingles may be difficult to live with while the disease is running its course, the only lasting complication from the disease is the postherpetic neuralgia. The prognosis is less favorable in patients with an underlying malignancy or those who are immunocompromised. Care includes symptomatic relief from the pain and itching and prevention of a secondary bacterial infection. Cold compresses, calamine lotion, and diversional activities are sometimes helpful. Teaching imagery, deep muscle relaxation, or the use of distraction activities can help decrease pain. If lesions are disseminated, meaning widely dispersed, or if the patient is immunocompromised, airborne and contact precautions are necessary until all the blisters are crusted. Fungal infections are called mycoses. There are 2 groups of fungi that cause infections in humans: fungi that are truly pathogenic to humans, and fungi that cause opportunistic infections. True pathogenic fungi can cause infection in an otherwise healthy person, but relatively few fungi are able to do this. The most common types of fungal infections involving the skin are Tinea pedis, Tinea cruris, Tinea capitis, and Tinea barbae. Monolithiasis, or thrush, is a fungal infection that can attack the mucous membranes of the mouth, rectum, and vagina. The skin fungal infections produce itching, some swelling, and a breakdown of tissue. Because fungi thrive in warm, moist places, a tropical climate or other environmental factors that produce prolonged heat and moisture will encourage the development of fungal infections. Hands and feet should be dried thoroughly after becoming wet, with special attention to drying between the toes or after a shower. There are many side effects of oral antifungal medications. Liver function should be monitored during administration. Diagnosis of fungal infections is confirmed by microscopic examination of skin scrapings that have been treated with potassium hydroxide solution. Patients should be taught how to prevent recurrence of fungal infections. Tinea pedis affects the feet, particularly between the toes. The infection may spread to the entire foot and cause blistering, peeling, cracking, and itching. Most cases of tinea pedis are contracted and spread in swimming pools, spas, showers, and other public facilities of this type. The skin between the toes become inflamed and develop cracks that become painful fissures. Intense itching is common. Diagnosis is by physical examination. Treatment of tinea pedis consists of keeping the area dry, clean, and exposed to air and sunlight as much as possible. Most of the prescription medications are available over the counter in a lesser concentration. Systemic treatment for stubborn infection includes oral itraconazole and terbinafine. Encourage the patient to keep their feet clean and dry and to wear clean cotton socks every day. Daily application of the topical agent must be done diligently to eradicate the problem. The patient should use only their own towel, and the shower or tub should be thoroughly cleaned and disinfected after bathing to prevent transmission to other family members. Personal footwear should be used in public places, like the swimming pool and the showers at the fitness center, and feet should be washed and dried thoroughly after using any public facilities. The parasites that cause pediculosis and scabies are found throughout the world in all types of climates. They can infest anyone. The parasites are particularly troublesome, however, where people live in crowded conditions and do not maintain their personal hygiene. The occurrence of pediculosis and scabies in the United States has recently increased significantly due to the growth of the homeless population and communal living. 3 basic types of lice that infest human beings are the head louse, the body louse, and the pubic or crab louse. In addition, human beings can also be infested by Sarcoptes scabi, the mange mite that produces scabies. All types are acquired through contact with infested people or their clothing, bed linens, and bedding. Pets have also been known to carry lice and the scabies mite. The most prevalent symptom of louse infestation is severe itching. The resultant scratching can lead to excoriation of the skin and secondary infection, causing impetigo, furunculosis, and cellulitis. If the lice infest the eyelids and eyelashes, the eyelids will become red and swollen. The scabies mites burrow under the top layers of the skin and live their entire lives there. They are more likely to be found in the skin between the fingers and toes, in the groin, and in other areas where there may be folds of skin. Secondary infection is not uncommon with scabies, and some deaths have occurred when the scabies infestation has led to pneumonia or septicemia. Diagnosis is by body inspection and by examination of skin scraping of a lesion under the microscope. Lice eggs are deposited at the base of hair shafts and can be seen on close inspection. Scabies causes curved or linear white or erythematous ridges in the skin that are clearly visible. The drugs most commonly used and considered most effective against lice and scabies are permethrin, pyethrins, and malathion. Some are available over the counter. These substances must be used carefully and the patient's liver function monitored because they can be very toxic. A fine-toothed comb is used to remove the nits that may have remained in the hair. Benzyl alcohol lotion is effective for head lice. Contact precautions are recommended. In addition, clothing, bedding, hats, stuffed animals, and other infested articles should be decontaminated to prevent reinfection. Laundering in hot water and machine drying using the hottest cycle is effective. Dry cleaning of non-washable bed coverings or clothing can also be effective. For items that can't be cleaned, like some stuffed animals, sealing them in plastic bags with the air expelled for 14 days can be effective. All family members must receive instruction about the infection and ways to prevent reinfestation. Skin cancer is often neglected because no pain is associated with it, and patients fear that treatment will involve extensive or disfiguring surgery. More than 5 million cases of basal cell and squamous cell cancers occur in the United States each year. These are highly curable cancers. Most melanoma deaths could have been averted through early diagnosis and treatment. Several factors predispose an individual to developing skin cancer. Among these are internal changes in the cells that may be caused by hereditary factors and external influences, like chronic exposure to ionizing radiation, petrochemicals, or vinyl chloride, or to other irritants in the environment. Sunburn as a child is a particular risk factor. Those with light complexion have a 24-fold greater risk of developing melanoma than African Americans, and before age 45, the risk is higher for women than men. Heavy exposure to UV radiation is a risk factor. This can be from alteration in the ozone layer inflicting exposure than in years past or long periods in the sun. Indoor tanning beds have been labeled carcinogenic to humans by the International Agency for Research on Cancer. You should instruct all people about the dangers of sunning without an appropriate protective sunscreen. Signs and symptoms vary according to the type of lesion. Diagnosis is by examination, biopsy, and pathology study. The three main types of skin malignancy are basal cell carcinoma, squamous cell carcinoma, and melanoma. Basal cell carcinoma usually appears first as a small, scaly area and tends to become larger as the disease progresses. It occurs most commonly on the face and trunk. If such a sore has not healed within a month, it may be a basal cell carcinoma. Even though these malignancies do not metastasize, they can invade the underlying tissues and death can result from complications like infection or hemorrhage from encroaching into a blood vessel. Squamous cell carcinoma is caused by sunlight, affects the epidermis, and can become invasive and metastasize to other areas of the body. It appears on the head and neck most frequently. The tumor begins as a small nodule that rapidly becomes ulcerated. Treatment must begin early if the condition is to be relieved before the skin cells sustain extensive damage. Cryotherapy, topical chemotherapy, laser surgery, and either topical or injected immune response modifiers are all used as therapies. Malignant melanoma is the least common form of skin cancer, but causes most skin cancer deaths. It arises from pigment-producing cells and varies in its course and prognosis according to its type. Causative factors are genetic predisposition, solar radiation, and steroid hormone influence. In general, the superficial lesions can be cured, but the deeper lesions will tend to metastasize more readily through the lymphatic and circulatory systems. Malignant melanoma always requires surgical removal of the tumor and excision of adjacent structures and possibly nearby lymphatic structures. Chemotherapy may be used to destroy tumor cells believed to have migrated beyond the tumor site. In advanced cases, newer immunotherapy drugs are being used to enhance immune function. The type of removal of cancerous skin tissue will depend on the type of malignant growth present. In all but the most extensive growths, treatment is relatively simple and completely successful if started early. Although benign precancerous lesions do not inevitably develop into malignant lesions, the most advisable course of action is to remove them when they are first diagnosed. Removal is performed by surgery, electrodesiccation, cryosurgery, topical application of 5-fluorouracil interferon therapy, laser therapy, and molecular therapy. Radiation therapy is sometimes used to destroy the cancer. While performing daily care of patients, you are often in a position to notice these lesions in their early stages, and you should do your best to persuade the person with such a lesion to seek prompt medical attention. For hospitalized patients, notification of the healthcare provider is indicated. Because people who have skin cancer run a high risk of eventually developing another malignancy, either at the original site or elsewhere in the body, they should visit a provider at least once a year after the skin cancer has been cured. On page 1007 within table 43.1, you can read about the 3 major types of skin cancer. When a patient is on bed rest or constantly sitting due to paralysis, pressure is against the skin in various areas and can interfere with circulation. Because cells die very quickly without adequate blood supply, pressure injury can develop. Depending on the patient's general condition, weight, and other factors, skin damage may occur within a few hours to a few days. Areas most prone to pressure injury are those over bony prominences. Shearing action can cause damage to the skin if the patient is slid along the sheets for positioning rather than lifted. The term ulcer has been replaced by injury, and the term ulcer is only used if an ulceration is present. Every patient needs and deserves good skin assessment, but there are risk factors that make some patients more susceptible to problems, like confinement, immobility, incontinence, malnutrition, decreased level of consciousness or confusion, obesity, diabetes mellitus, dehydration, edema, excessive sweating, and extreme age. Pressure relief, positioning, padding, use of pressure relief devices, adequate nutrition, and excellent skin care are the hallmarks of pressure injury prevention. Pressure injury can be very costly to the healthcare system, costing about $10 billion and 60,000 deaths annually. Once a patient has developed a pressure injury, treatment will depend on the stage of the lesion. These assessment tools will consider the general condition of the skin, control of urination and defecation, mobility, mental status, cleanliness, and nutritional status. They provide a more systematic approach to evaluate a patient's potential for pressure ulcer development. Many agencies either use the Braden scale system or the Norton system for systematic assessment of the skin. The presence and stage of any tissue injury should be documented upon admission to any healthcare facility or service. A staging system for classification is used. A suspected deep tissue injury is intact skin with a purple or maroon discoloration. A stage 1 injury is an area of intact skin that is reddened, deep, pink, or mottled and does not blanch. A stage 2 injury is a partial thickness skin loss involving the dermis and/or epidermis. A stage 3 injury is where the skin is ulcerated. A stage 4 injury is where there is a deep ulceration and necrosis involving deeper underlying muscle and possibly bone tissue. An unstageable injury is a full-thickness wound with eschar and/or tissue that is obscuring depth determination. A technology called pressure mapping will help identify areas of high pressure. The patient lies on a sensor-filled mat, and the mat sends sensor data to a computer, which creates a display of color-coded images. Red areas indicate higher pressures, and blue or green areas suggest lesser pressures. It is being used to identify best practice to prevent tissue injury from pressure and shearing. This technology is being used to identify best practice to prevent tissue injury from pressure and shearing. Removal of any eschar, must occur for a pressure ulcer to heal. The exception is a heel ulcer with dry eschar that has no edema, erythema, drainage, or boggy tissue. Debridement can be done surgically with forceps and scissors or mechanically. Mechanical debridement is accomplished by whirlpool baths, wet to dry saline dressings, dextranum or beads sprinkled over the wound, or other proteolytic enzymes or chemical products that break down the dead tissue and absorb the exudate. Wet to dry dressings are not recommended due to the damage that occurs to new granulation tissue when removed. Dressings that keep the wound moist should be used. Surgical debridement may require a skin graft to cover the area exposed. Whenever surgical debridement, forceful irrigation, or whirlpool debridement is to occur, provide sufficient analgesia for the patient because this procedure is painful. Many hospitals and larger long-term care facilities have a wound care nurse specialist who oversees wound treatment. You should consult these specialists for valuable advice about wound cleansing and dressing materials. Normal saline or other non-toxic solutions like SureCleanse and light mechanical action with sponges or irrigation equipment is a way of cleansing that prevents disruption of granulation tissue. A reddened wound bed requires gentle irrigation with a 30 to 50 ml needleless syringe to prevent damage to newly developing tissue. Wound dressings are selected according to the characteristics of the wound. Common dressing materials include moisture-retentive dressings, hydrogel dressings, hydrocolloid wafers, alginates, biologic dressings, and absorptive dressings. Use hypoallergenic tape when tape is necessary. Choose a dressing that keeps the ulcer moist and surrounding skin dry. Prevent abscess formation by loosely filling all cavities with dressing material. Pressure must be kept off the wound for it to heal. Application of electrical stimulation increases the rate of healing of pressure ulcers, venous leg ulcers, and diabetic foot ulcers. Application of an electrical current to the skin has been in clinical use for several decades. The therapy requires bulky equipment for generation and delivery of the electrical therapy. Negative pressure wound therapy is used effectively for chronic wounds, speeding healing time. NPWT is used on other types of wounds as well. Suction tubing is attached to the port and then to the vacuum source. The foam dressing facilitates suction applied to the full surface of the wound. The subatmospheric pressure stimulates the formation of granulation tissue and pulls away exudate from the wound. For an ulcer that will not heal using other methods, hyperbaric oxygen therapy may be prescribed if the equipment is available in the community. Tissue becomes flooded with more oxygen than is normally available when breathing atmospheric pressure air. Pressure ulcers should be measured and documented when they are discovered and at least once a week thereafter. Document the characteristics of the wound and any exudate present. Exudate is typically purulent or serosanguinous. Serosanguinous exudate is amber-colored and blood-tinged. Purulent drainage may be one of several colors. All aspects of risk assessment, preventative measures instituted, objective description and measurement of pressure ulcers, treatment, and progress towards healing should be documented regularly in the patient's chart. Photographs are usually taken of the ulcer upon discovery and during treatment to document progress. Burns or injuries to the skin caused by exposure to extreme heat, hot liquids, electrical agents, strong chemicals, or radiation. Inhaling smoke or fumes also causes injury. Fire and burns kill approximately 4,000 people each year in the United States. Today, because of fluid resuscitation, burned wound excision and grafting techniques, new skin coverings, and nutritional supplementation, a patient could survive a 99% burn. Today, 96.7% of patients treated in a burn center will survive. Many will live with lifelong disabilities and scarring. Electrical burns damage tissue deep within the body. The extent of damage is not always visible, and the entrance site and exit site may appear small. Cardiac monitoring should be initiated even if the patient does not complain of chest pain. Chemical burns result from accidents in homes or industry. The severity of the injury depends on the duration of contact and the concentration of the chemical. Radiation skin injury is typically from therapeutic radiation treatment. In industries in which the radioactive isotopes are used, the degree of injury will depend on the amount and type of energy deposited over time. Burns will cause an acute inflammatory response. Serious burns have local and systemic effects. All burns should be considered potentially life-threatening until they are thoroughly assessed. When a burn area is large, the inflammatory response can result in a massive shift of water, electrolytes, and protein into the tissues. This causes severe edema. Hyperkalemia occurs when potassium is released from the damaged cells. Hyponatremia is caused by the stress response and potassium shifts. Metabolic acidosis develops. The loss of fluids from the vascular space leads to hypovolemia with low blood pressure and possible hypovolemic shock. There is danger of kidney failure from both the hypovolemia and the cellular debris that the kidneys must clear from the body. If the burn was caused by a fire, lung tissue injury from inhalation of heat and smoke could cause alveolar edema. The decreased perfusion to other organs causes changes in the gastric mucosa that could impair its integrity. Fluid replacement is essential. Burn severity depends on the cause, the temperature and duration of contact, the extent of the burned area, and the anatomic site of the burn. Signs and symptoms will vary from slight reddening of the skin to full loss of tissue down to the bone, with black charred areas. Blisters may form. Diagnosis of the depth of the burn is made based on a classification system. The classification of burns is based on the amount of the body surface that has been burned and the depth of the burn. The extent of a burn is roughly calculated outside of the hospital using a rule of nines, and this is expressed as a percentage of total body surface. Burns are a prevalent pediatric injury as well, and children cannot be assessed using the standard rule of nines. Similar charts with different percentages or charts specific to pediatric patients, like the pediatric Lund-Browder chart, should be used. The depth of a burn is more difficult to determine due to various gradations of injury being sustained in a major burn. A more current method to evaluate the depth of the burn is based on the layers of skin that have been damaged. Epidermal or first-degree burns involve only the superficial epidermal layer and usually do not need treatment. Superficial partial thickness wounds are considered second degree. These are which the epidermal appendages are not destroyed and the wound will heal by itself if no further injury occurs from either infection or inappropriate treatment. Deep partial thickness wounds are second degree as well. They include tissue through the lower layer of the dermis and will require surgical treatment. Full thickness wounds are considered third degree. These involve all layers of the skin and the destruction of the epidermal appendages. Wounds of this type will require grafting for the wound to heal and for optimal function to be restored. First, all burn patients are treated as trauma patients. Establishment and maintenance of an airway is the first priority. Hemorrhage does not usually occur with burns. Generally, patients are undressed and covered with a sterile or freshly laundered sheet. However, clothing that is stuck to the burn area should not be removed before the patient is in the hospital. Rings, bracelets, and watches should be removed from injured extremities to prevent a tourniquet effect when swelling occurs. Blisters should not be disturbed initially because they serve as a protective covering over the wound. Patients with serious burns are generally given nothing by mouth. Assessment for carbon monoxide inhalation includes checking the mucous membranes for a cherry red color. Intravenous fluid therapy and more extensive medical treatment should be started as soon as possible. The emergent phase averages 24 to 48 hours, but may last for as long as 3 days. It begins with fluid loss and edema formation and lasts until edema fluid is mobilized and diuresis begins. The first hour of treatment after burning can be crucial to the eventual outcome of a serious burn. Other life-threatening injuries must be treated first. Knowing the causes of the burn and whether there is any possibility of thermal damage to the respiratory tract can alert the team to specific needs of the patient. The depth and extent of the burn area are estimated, and multiple IV lines are established. A tetanus toxoid injection is given in the emergency department. It is the only IM injection given initially. There is a potential for respiratory obstruction if upper airway passages have been burned. Swelling will occur, and it will become increasingly difficult for the patient to breathe. Signs of respiratory distress, like increased respiratory rate, the use of accessory muscles, nasal flaring, retractions, restlessness, and confusion may occur. Early intubation is recommended for an extensive upper airway injury. Lower airway injury is caused by breathing in smoke and soot from the fire. This type of injury could also require intubation and ventilation and may be life-threatening. Patients who should be watched closely for signs of developing respiratory problems include those who have burns of the face and neck, singed nasal hair or darkened membranes in the nose and mouth, smoky smelling breath, dark or black sputum, burning sensations in their throat or chest, or a history of having been burned in an enclosed space. General first aid for minor burns can be seen on page 1015 in box 43.3. Watch for increasing restlessness, coughing, hoarseness, rapid shallow respirations, stridor, and falling oxygen saturation. Keep necessary equipment at hand and constantly assess the patient's respiratory effort. Use an incentive spirometer, coughing, turning, and early ambulation to maintain good respiratory function. A major concern in the care of a burn victim is to prevent shock from circulatory collapse. The two most important measures are used to relieve profound shock in a burn patient includes the replacement of lost fluid and electrolytes and the enhancement of tissue perfusion. The loss of fluids and electrolytes results from sudden capillary leak and shifting of the blood plasma and tissue fluids from their normal site to the area of the burn. This shift occurs in the first 24 to 48 hours after the burn. The Parkland formula for fluid resuscitation can be seen on page 1016. 1/2 of the required fluid should be given within 8 hours of the time of the burn. The second half is given over the next 16 hours. After that, fluids are based on specific volume and electrolyte imbalances and response to treatment. Fluid replacement is calculated from the time of injury, not from the time of arrival at the medical facility. Unless fluids are replaced immediately, the cardiac output will drop, and the resultant profound shock may be fatal to the patient. The patient's vital signs should be checked hourly and recorded accurately. An arterial line may be inserted for more accurate monitoring of blood pressure changes. The state of sensorium or level of consciousness is another key observation in the assessment of tissue perfusion. Constantly assess the patient's level of alertness and clarity of thinking, asking the patient who they are, where they are, their age, what happened, and so on. It is very important to monitor the signs of adequate fluid resuscitation and to know when to decrease or increase the fluids based on clinical findings. After the first 24 hours, 5% dextrose in water is given to maintain a serum sodium level of 135 to 145 milliequivalents per liter. As soon as IV lines are established and fluid resuscitation is begun, pain control can begin. Measures to relieve pain include the administration of IV morphine or hydromorphone hydrochloride. Fentanyl is another powerful opioid medication that can be combined with a benzodiazepine like midazolam before painful wound care procedures. The massive fluid shifts that occur after a burn injury make absorption from an IM site unpredictable in the first 24 hours after the burn. For chronic pain, gabapentin and methadone can be prescribed. To prevent gastric distension secondary to mesenteric vasoconstriction, an NG tube can be placed. Within 24 hours of injury, tube feedings can be initiated to help provide needed nutrients for healing and to counter the hypermetabolic burn response. The acute phase extends from the time of fluid mobilization and diuresis to when the burn area is completely covered by skin grafts or when burns are healed. Goals during this phase include management of pain and anxiety, prevention of wound infection, promotion of nutritional intake, and rehabilitation therapy. Although wound infection is no longer the major cause of death in burn victims, its prevention is important to recovery. During the granulation stage of repair, the wound should look slightly pink and somewhat shiny. Healthy granulation tissue does not emit exudate. A very wet wound that has a foul odor indicates infection. Signs of infection should be reported to the healthcare provider. Critically burned patients have a high risk for pneumonia. Pneumonia in hospitalized patients could be ventilator-associated, hospital-acquired pneumonia, or non-ventilator hospital-acquired pneumonia. The addition of inhalation injury will put the patient at further risk. General principles for the care of burn wounds include keeping the subendothelial layer moist, preventing infection, promoting healing, and minimizing pain. Antimicrobial ointments are used topically to prevent colonization of the wound. Superficial burns may then be covered with a non-adherent dressing like Xeroform, Adaptic, or Mepitel. If healing tissues are normally in moist environments, they will heal best if kept moist and not allowed to dry out. Surface skin that is normally dry should be allowed to dry for healing. Burn wounds are cleansed with sterile saline using sterile technique at least once daily. Prior to wound care, analgesics should be given. Wounds of the face or ears are left undressed. After the wounds are cleaned, a topical ointment like bacitracin is usually applied every 8 hours to prevent infection and promote healing. eschar is a source of infection and it impairs healing. If removal of eschar is not possible, tissue perfusion or quality of respiration can become compromised due to circumferential eschar constriction and eschar being performed. An incision into the burn and eschar with a scalpel or electrocautery will relieve pressure caused by circumferential burns that encircle an extremity or constrict movement of the chest. An eschar on the chest improves lung expansion and oxygenation. The procedure does not cause discomfort because the nerve endings have been destroyed by the burn. No anesthesia is required. Be alert for compartment syndrome, which occurs when increased pressure within a compartment causes compromise of circulation to the area. Fluid accumulation from edema can cause compartment syndrome in burn patients. Monitor for increasing pain, paleness and tenseness of the tissue, numbness or tingling, discoloration in the distal portion of the extremity, and decreased sensation. Debridement may need to be an ongoing process as the full depth of the burn is realized. Mechanical techniques like soap and water, moistened gauze, or chlorhexidine surgical scrub brushes can be used if irrigation with sterile saline is ineffective and removing the dead tissue. Large wound debridement is done in the operating room. Surgical removal of eschar and applications of biologic dressings are done within the first few hours after the burn injury. Biologic dressings are materials obtained from cadavers or from animals. The many synthetic dressings available consist of silicone, plastics, or alginate and remain in place for 1 to 14 days. The patient's own skin is the only permanent graft material. When autografting is performed, there is a donor site from which a split thickness piece of skin has been removed. Recovery time from a split thickness skin graft is rapid, commonly less than 3 weeks. Donor sites may be covered by a film dressing to hasten healing and decrease pain. The donor site is often more painful than the graft site. Pressure dressings are worn as soon as grafts heal to decrease the scarring that can inhibit mobility. The pressure dressing may be an elastic wrap or a custom-fitted, elasticized piece of clothing that provides uniform pressure over the burned area. The pressure dressings must be worn 23 hours a day, every day, until the scar tissue is mature. Scar maturity takes 12 to 24 months. When a sizable burn occurs, blood flow is shifted to the brain, heart, and liver because of the fluid changes that occur. The GI tract receives decreased blood and gastric motility is impaired. Monitor for peristaltis and be alert to signs of paralytic ileus. A histamine H2 receptor antagonist like cimetidine, ranitidine, famotidine, or nizatidine can be administered IV to prevent this complication. Contractures are always a threat with major burns and sometimes with minor burns. Proper positioning and regular exercise are essential to prevent musculoskeletal deformities after a burn. Although the motion of physical therapy exercises may be painful, the muscles and skin must be exercised and stretched every day for normal motion to be maintained. Ambulation 2 to 3 times a day is begun as soon as the fluid shift has stabilized for patients who have no fractures or serious injuries to their feet or legs. A patient who has experienced a major burn is transferred to a rehabilitation facility. The rehabilitation phase begins with wound closure and ends when the patient reaches the highest level of function possible. This phase could last for years. Continued physical therapy and psychological care are essential to help the patient achieve their optimal level of function. Teach the patient how to apply topical agents without contaminating the wound and how to change dressings if these are used. A family member, if available, is included in burn care education. Maturing scars usually appear red, hard, and raised before they eventually begin to fade and soften. Pressure garments and masks help prevent thick and disfiguring scars, but they are uncomfortable. The patient may resist wearing them unless there is an understanding of their intended purpose. Your encouragement and reinforcement of the purpose can help. Reintegration into roles, community activities, and employment will take time. Participation in a support group of burn victims is sometimes helpful. Having friends visit and making short trips out in public is helpful in dealing with the reactions of others to burn scars and disfigurement. Care of a burn patient is interdisciplinary. Collaborative planning meetings should be scheduled at least once a week initially. Input for the plan of care is contributed by all members of the team. The patient's vital signs and pain level should be checked and recorded at regular intervals. The condition of the wounds should also be assessed systemically to determine whether healing is taking place as it should and infection is being prevented. Wounds are carefully assessed at each dressing stage. Signs that indicate infection include a strong odor, color change from dark red to dark red or brown, redness around the edges extending to unburned skin, texture change, exudate and purulent drainage, or the slowing of the graft. Use gentleness and care in handling the patient as they are turned or treatment is administered. Despite advances in burn care, research studies show that pain continues to be undertreated, and even experienced clinicians will tend to overestimate the efficacy of opioids. Morphine or hydromorphone hydrochloride should be administered with a PCA pump when possible. Boluses are necessary before treatments or surgical procedures and at bedtime. Burn pain can be distressful for years after the burn occurs. Pain continues even after the wound appears to have healed completely. Exercises to prevent contractures can cause pain because they stretch the skin while it is very tender. Splints to prevent musculoskeletal complications can also cause discomfort. Analgesics will allow the patient to get sufficient rest, but they should be given judiciously as the pain becomes less acute. An aseptic environment is needed for burn care. Standard precautions are used for all burn care, and private rooms are recommended. Those in attendance should wear caps, gowns, and gloves while caring for the patient as a protective measure. Gloves are worn for all contact with open wounds and are changed whenever handling wounds on different areas of the patient's body and between handling soiled and sterile dressings. Patient care items should not be shared, and great attention is paid to maintaining asepsis for all patient care. The treatment of post-burn itch is a complex issue requiring trial of various treatments. Oral antihistamines are effective in many patients. Non-pharmacologic measures to reduce itching, like massage, TENS, music therapy, and botulinum toxin, can be used along with medications like gabapentin. Enteral feedings are started within 24 to 28 hours after injury. Early feeding helps prevent ileus and provides needed nutrients. If enteral feedings are not tolerated, parenteral nutrition is provided. A diet high in protein and calories is necessary for healing. Nutritional needs may be increased 50 to 150% above normal, and increased requirements can continue for 9 to 12 months. Only high-calorie liquids are given to drink. Free water intake is restricted. Consultation with a nutritionist is essential due to the dietary issues that can occur for burn patients. Burn patients may face loss of mobility and independence or disfigurement involving the face or other parts of the body usually visible to others. Many experience post-traumatic stress syndrome, and others may feel guilt, anger, or depression. Strive to develop an attitude of acceptance of the patient, a calm approach to addressing changes and discussions of scar formation, and an optimistic emphasis on what the patient can do and will be able to do in the future. Facility chaplains, counselors, social workers, and other team members can help the patient work through their feelings. Encourage the patient to ask questions and to verbalize their concerns about the care and treatment plan. Involving the patient in performing self-care as much as possible and giving some sense of control over the situation are helpful. The patient's body image may have been severely disrupted. Assist the patient to grieve over the loss and integrate the present body image. If the burns were caused by a suicide attempt or risky behavior, psychiatric therapy will probably be necessary to deal with feelings of guilt. Although males and children younger than 4 years are more likely to experience burns, female patients tend to have a greater adjustment difficulty with altered body image. Referrals to a psychologist, psychiatrist, social worker, or religious leader may also be necessary. The patient and family are taught about daily skin and wound care before discharge. Moisturizing with an alcohol-free skin moisturizer is necessary at least 3 times a day. Direct sunlight should be completely avoided for 1 year after injury due to increased sensitivity to UV rays. Referral is made to support groups or peers and counseling as needed for readjustment to life after the burn incident. The need for follow-up care is stressed and appointment dates and times are established. A systematic and ongoing assessment of scar tissue formation should be performed and evaluated to determine whether the patient is making an adjustment to the fact that burn scars may take as long as 12 to 24 months to mature completely. If outcomes are not being met, intervention should be changed. Nurses in the community can do much to educate the public about the dangers of unprotected sun exposure and the signs of skin cancer. School nurses perform assessments for signs of lice and scabies. They teach families how to deal with these problems and how to prevent their spread. Teaching fire safety to children and parents and workers in various occupational settings can help decrease fire injury.